Welcome to another episode of Harbor Rock Wealth Management's podcast series, Life, Health, and Wealth, where we discuss financially driven topics and how they relate to our lifestyles. Take a breath. He's Reuben Smith. I'm Jimmy Luster. And today we have a very special guest, someone that we've had the pleasure of actually working with for many years now. Going back, Sandy Platamone, who is a hospice registered nurse for Salus. And let me tell you, she's a busy lady. It's a very important job. And we don't quite know your schedule all the time, especially when we're trying to get together for our meetings, right? You know, you're kind of at the call of nature and what's going on. But we're very happy to have you give us a little time today this morning and to discuss a really important topic that I think plenty of us have a lot of questions about. Probably a lot of us don't want to really talk about. It's a delicate subject.
It is.
End of life. Yeah.
Well, thank you.
That's it. That's a wrap.
It's as much, dying is as much a part of living. So that's what we'll talk about.
Yeah, I liken it to, we do a lot of financial planning for clients. And when we suggest or we see a hole in their estate plan, or we talk about life insurance or long-term care insurance that end of life, that the idea of their own mortality or ailments and no one likes to talk about that, but
I love to talk about it.
Yeah,
but I was going to say,
person for the job.
Knowing you for a long time now, I think you're actually you have the perfect personality for the job and the perspective on life, and so I'm excited to where the show goes because I think it's a very important topic that we address all the time with clients, and I think it'd be a good resource for our clients to tune into.
Well said. Yeah. Well said. Kind of got a couple stats.
Okay.
It wouldn't be a show without them, but they'll be brief because we got a lot to talk about.
Okay. Yeah.
I read various numbers on this on what is the average time an American spends on hospice once on hospice. 92 days, just under 93 days.
That's a good case. I would say that's a good hospice case.
Okay.
But go ahead.
Okay, we'll get to that on why that is a good hospice case. Yeah. Also, just over half of Americans will utilize hospice at one point. I read that half of the people that die on Medicare are on hospice. So, just some interesting numbers.
Probably should be more than that.
It feels like it would be. Yeah. But, and then actually you and I were having a discussion, a little pre-planning this morning for the show, and we came across a little saying that I think is cool, and I'm going to remember it.
Some hospice humor here?
Some hospice humor.
Okay, go ahead.
Do you only live once? The answer is no. You actually live every day. You only die once.
Yeah.
So I like that outlook. Yeah. Keep living. And another one that I thought was cool that I found yesterday, and I am going to mention his name, BJ Miller. It's someone that I don't know a lot about, but very impactful. I watched his TED Talk yesterday. Everyone should check out BJ Miller. He has a great story to tell. So when you get a moment, you can YouTube that as well.
It's pretty impactful.
Pretty awesome. And he said, a hospital is a place to treat illness or intervene to save a life. It's not a place to live or die.
Wow, I like that. Yeah. I like that. And you think about, when we talk about clients and end of life planning and should you need long-term care services or hospice services, do you want to be in a facility? Do you want to be? I mean, I think most everyone would like to be in the comfort of their own home, in their familiar surroundings.
You would think, but not everybody.
Really?
And the shift from hospital care to hospice care is a mind shift for sure.
Okay.
So we should probably talk about what hospice means, maybe.
Yeah,
I love it.
Yeah. So let's start with a little bit about your background.
Oh, me.
So,
I could talk for okay. I'll give you the condensed version.
Who are you, and how'd you get into what you're doing?
Yeah. Well, I fell into what I'm doing literally. I worked in a hospital setting for more than 10 years, where I was a hospital nurse. Get them better, get them out. Completely different mentality. Never knew the hospice term, really. I mean, I knew the term, but we didn't deal with that in the hospital. And I loved what I was doing. I loved being all I ever wanted to do in my whole life was work in a hospital, and I was doing it. And then, life threw me a curveball, as it does sometimes.
Sure.
And I found myself widowed with a small child, and everything changed. I mean, everything changed, and I moved. I did exactly what you're not supposed to do when somebody dies. I changed my whole life. And I moved down here, and I sort of pieced my life together for a year or two until I could figure out what to do with a little one. And finally, one day I said, okay, I think I can go back to work now. I think I'm ready. She's in school and I can do something. And a friend said, well, I know somebody who does this home health thing. I'm like, I didn't know anything about home health.
Okay.
And so I made a phone call. I just, kind of being in that foggy place still, I made a call, and lo and behold, it was hospice. And I was like, okay, when do I start? And that's sort of always been my nursing jobs. I just know I can do it. And I just went in and did it. And never realizing what a specific specialty it was.
Sure.
Yeah.
And now, at least 21 years later, I'm still doing this job.
Wow.
Still. So there's been so much to learn. And I think that sometimes people might, even maybe other healthcare professionals might look at hospice as, yeah, they just do hospice. It's not a big deal. But it is a big deal.
Sure.
There's a lot to learn, not only regarding pain management, but psychosocially. Everybody wants to know, when is this going to happen? And so there's a lot of plates that you're juggling in the air with this job at all times. So,
well, let's talk about what is hospice.
Yeah,
I don't think a lot of people know exactly what that is.
Well, I think a lot of people think hospice and palliative are the same thing. So those are two separate things. So let me just start first with palliative, which is a subspecialty of this big umbrella term. So palliative care can start right at a person's diagnosis. So let's say they get a diagnosis of whatever. It could be a cancer where they're not on death's door.
Okay.
And they still want treatment.
Gotcha.
They can be on palliative care and still have symptom management. Still go out to doctor's appointments, maybe get chemo if that's what they choose to do, get labs done and all that. And then if and when their diagnosis becomes terminal, then they slide over to hospice.
I gotcha.
So hospice is a terminal diagnosis, which, if it runs its normal course, defined as, a terminal diagnosis, it should last 6 months or less.
Okay.
You'll be gone. Not always. I mean, that's give or take. But hospice care is end-of-life comfort care.
Comfort, right.
No aggressive treatment. You're not going to the doctor. You're not getting MRIs. You're not getting labs. You're not getting CAT scans. You're not getting chemo. You are at home in the comfort of your own home. Or, well, not always at home. Sometimes it could be in a facility, and I would go to that facility. But not in a hospital. Could be in an assisted living.
A specialized place, a specific place.
Not necessarily specialized for hospice. It could be any of the assisted living places around here that you're getting hospice in there.
I got you.
So.
Okay, yeah, because I just think of it as you're going to someone's home.
Yeah, that's the best.
That's
I
optimal,
think the best.
Probably.
It's optimal.
But yeah, you're going where you're needed. I mean, okay.
Yeah.
Interesting.
So it's a little bit different in each place. We have a little bit more. It's a little, I don't want to say looser in a home, but these facilities have a lot of guidelines they have to go by.
Sure.
And at home, it's a little bit like I think it was intended to be.
Yeah. Okay. I got you. Now you mentioned 92 days.
That's what I read.
So that does sound like a good hospice. Now I feel like I've heard of people where people have been on hospice for much longer than 6 months.
Right.
Yes, it happens. There's a few diagnoses that are harder to predict. One of them being any of the dementia type of diagnoses, because a lot of times a person they'll just take a few steps down and, oh, that's it, put them on hospice, and then they stay there for a long time. So that's another guideline for hospice. You have to always be charting to a decline. You have to show that this person is taking steps down, not up, like in a hospital. So there are times when they would be discharged for extended prognosis sometimes.
Okay.
But that being said, they can still come back on if and when they decline again. But that's not usually a cancer diagnosis. That's usually a dementia.
More cognitive.
Okay.
Yeah.
So I've been through this personally.
You have, I know.
What an experience. Beautiful, horrible, all at the same time.
Yeah.
I mean, and there was a lot of activity going on the daily.
Especially in the beginning, huh?
Yeah. I remember people were visiting the house. Our heads are spinning.
Yeah.
We're processing. We're very appreciative of everything, but we're like there's a sense of just get out, just give us a minute,
Yeah.
like,
Yeah.
and at the end, God bless everybody.
And I try to be cognizant of that at all times.
Right.
Yeah.
They were all amazing. And I know, so there's a team. I mean, this is not one individual who shows up, opens up their shirt, and they have a cape on and a Superman logo. I mean, this is a team of folks that were fantastic. So speak to the role of the hospice team.
Okay.
And the role of the family.
Okay. Before we do that, can I say one other thing that I think is really important that I don't think people know about? And that is, you can choose any hospice you want. There are literally hundreds of hospices in Orange County. I don't even know about LA County. But let's say you end up in a hospital and that particular doctor is affiliated with a certain hospice. Oh, you have to go with this hospice because this is the one I go with. Or you're in a facility. Well, this is the only company we like to work with. You can
so
choose.
they have choice.
I recommend interviewing 2, 3, 4 hospices. The formula is pretty much the same, but there are a few little minor differences that I would suggest people look for. And can I say what those differences are?
Please.
I would say that you want to know, if you're interviewing a hospice, you're going to get the liaison, who's basically the salesperson.
Yep.
And you want to ask that person, how much experience does my nurse have? The one that will be assigned to me. How many patients does she have to take care of? How far away from her territory does she live? Because if you're dealing with a company that their model is to let their nurses have 15, 20 patients, you can't take good care. In my humble opinion, you're not going to be as effective.
So someone with 21 years experience, what's your capacity?
Oh, right now I have about 12 patients, I think.
But is that your capacity? Is that's
my company? They're really good at doing exactly what I'm saying, which is why I love them and why I've stayed with them, because 12, 13 patients. I live where I work, so I've taken care of hundreds of people in this area: San Clemente, San Juan, Dana Point.
Mm-hmm.
For those poor nurses that have to drive 20 miles to get to their patients, you can't jump in the car if there's a problem, at 2:00 and get there.
Right.
So that's just one little caveat I wanted to make sure people know.
I appreciate that. I appreciate that.
Always choose.
And we've been through it with clients where, let's say, one of the spouses gets sick and is on hospice, and their head is spinning.
Yeah.
They know enough to know that they're not in love with the care that they're getting.
Right.
But they're also in a place where they're kind of numb to it and going through the motions and not really in a place to be able to say, hey, this isn't quite right. I want to shop around.
You can't shop around.
Totally.
And I would even go so far as to say, if it were me, I would say, before I choose your company, I would like to meet the nurse, because you might not click with them. There could be a language barrier. Who knows?
Well, I think a lot of people don't know. They don't know if they can ask questions or even do that.
You can.
And you're in such a time of
a vulnerable time.
You're timid.
Yeah.
You're walking on eggs a little bit, eggshells, and you're a little gun shy. It's not like, hey, I want to interview you.
Yeah. And you certainly can. So that's just something
great
I want to say. Yeah. So anyway, so when you do finally make the choice, if you get that far as to have the wherewithal to do that, then there's a team. You have, and the whole team, we work together. It's very cohesive. The nurse, who you have to have, obviously, a medical social worker who might visit every week, might visit once a month. Everybody's needs are different, and they have specifics that they do, not the least of which is just as another supportive person. You have a bath aide who people love, somebody to come help if a person's bedbound or they just need standby assist in the shower or something. The bath aide is there. We have the chaplain, the non-denominational chaplain. Not everybody wants a chaplain, but some people do. And again, it's
there.
Yeah, right. It's there. We have a volunteer team. So, for example, we have this wonderful volunteer on our team who goes to people's homes and cuts their hair. I just had a patient yesterday that got a haircut, and it just changed everything about how she felt about
Totally.
Wow. So that's wonderful.
Wow.
And the volunteers, they don't get used all the time, but when they do, it's really a cool thing.
Yeah.
So, the whole team works together, and
right.
hopefully we do a good job.
I think that's awesome. I mean, I don't know if we have ever actually shared this on the show, but one of the coolest things I think Jimmy does with his dad right now is he goes over and cuts his hair.
Oh,
You
yeah.
do?
Oh, yeah.
I love it. I love that story.
bowl?
I just they have a moment.
Is it the bowl? It's probably not as good as the bowl.
But it's
No,
just a moment that they have. And,
It is cool.
And
Yeah.
We put on some Buddy Holly radio, and
and
I
know
have the
your
talc
dad.
in my brush and give him the whole experience.
so
and
funny.
yeah, it's fantastic.
That's so funny. How
But it-
how long ago was your mom on hospice?
A couple of years ago.
And how long was she on hospice?
Well, I want to say gosh, it was like a blur.
Yeah, I know.
That was about a couple weeks max.
It is a blur, isn't it? Because
Couple
you know
weeks.
what? My husband was on hospice
Yeah.
too, and I can barely
Time
tell you
stood
anything
still.
about it.
Time
Yeah.
totally stood still.
Yeah.
I look back at that and I'm like, wow, my brain's really trying to protect me, because
Yeah.
that moment seems like
Yeah.
just one long,
Yeah.
sustained kind of
Yeah.
moment in time,
Yeah.
compartmentalized, which is also important to know. That's why you can't make rational decisions all the time, and you need
know.
help, and you need to ask questions. That's why it's got great advice about look around,
Yeah.
slow down.
Yeah.
Like
slow down.
down. You don't have to rush into making decisions.
Yeah.
You know.
And I think did you say something about the well, that's the role of the hospice team, but then the family.
So then there's the family element.
Yeah.
Now
Yeah.
I'll just speak to that a little bit. I was lucky. We were on the same page.
Mm-hmm.
My family dynamic is one that people would be jealous of, in my opinion.
Yeah. The kind of case we love, really.
Yeah. We between the time mom was diagnosed to when she passed was fast.
Yeah.
I mean, it was less than a year,
Uh-huh.
about 8 months from diagnosis. She had ovarian. So
Uh-huh.
very sleepy. And, we were in a position that we knew what was coming, but when all this things started really speeding up when we were in the hospital, and we were talking to hospice folks. And so
to
we
make
knew
decisions.
what was coming. So we had to prepare ourselves, but we had to prepare, mom to be in a position that she was comfortable.
Yeah.
And that would be my advice for anyone, is just to talk about these things earlier, than when it's time. Just like we always talk about. Plan for it. Like, know who's gonna do what. Now, when stuff's happening, plans get blown up. We say that all the time. But you're in an intense, high rev situation.
And it's so much more comfortable if you've already had a conversation.
Sure, let's
about
talk
You're already
about these
prepared.
things.
Yeah, it's as prepared as you can be.
And work together. You're not always going to agree on things, but you have this hospice group they're doing the best they can. Like no one stays in that for 20 years if they don't enjoy their work or shouldn't be doing that kind of work. So what advice would you have for the family, to create a better hospice experience?
Well, everybody comes into this with obviously a lifetime of experience and baggage, call it what you will, I think one of the hardest things is when a family says to us, don't mention the hospice word. Don't tell them they're in hospice. How can I do my job?
Yeah.
But we get that more than you would imagine. And I understand, everybody comes with a certain level of acceptance and or denial. So for me personally, I know that I know my job, and I know that I can do a great job if you will just trust me, But at the same time, I have to listen to you and know that the patient is the boss. I mean, I have a patient right now who has a terminal cancer, and I want to have everything in place that I know I need, including a few different pain medications, and she's just not having it. Nope. I'm like, okay. I said, you're the boss, I have to listen to what people want.
Well, I remember the hospice, I can't remember exactly if it was the nurse or some other individual, told us, it's not really my job to give the medication, necessarily, unless you want me to, or they're all, you guys actually,
So
you guys have to do a lot of this stuff.
So what does it take then? That's a lot of courage for the family, right? It takes a lot of courage for the family.
Yeah.
And not everybody has it. Not everybody.
No.
Everybody's stress levels comes out in a different way by getting angry with me or a member of my team because they're so afraid.
Well, that's probably what a experienced team is good at.
Yeah.
Is reading the room.
Yeah.
you know, and seeing where
You
they
really
need to
have
step
to read
in
the room.
or allow them to, because it might be cathartic for these folks to do some of that. Some people are terrified. They're like, I don't even want to look at this family member right now because it's screwing me up. You know, I don't want to remember them like that. Or,
Right.
Yeah.
Like,
And then we have to talk about uncomfortable things. Like we have to ask, you know, do you have a mortuary in place?
yeah.
Because at 2:00 in the morning, if that person passes, you don't want to think about it then.
Right.
But they don't want to talk about it.
Yeah.
But then there's people, oh, yeah, we have this, give you all the paperwork. They've done it all. And so we just have to go in knowing anything can happen.
Yeah.
And we have to adjust.
Yeah. So talk to us a little bit about some more advice, a lot of advice today from the expert.
More advice.
Right. About not waiting.
Oh.
Don't wait till the last minute to go through all these things again. You're speeding up the process if you're waiting till the last second.
I don't want to blame. I don't want to point fingers or blame anybody. But if you are in a hospital situation and you are a physician who treats people, they want them to get better. They're not going to give up. So a lot of times, I'm just going to say oncologists won't refer until the last second. Some will. Some get it. Or the family gets it. The person says, I'm done with this. I'm not going to do these treatments anymore.
So is that something the family, like how...
Families can say it.
The family steps up and goes, like, let's say this person's, you know, not in a psychological state in their illness to really make those decisions, or, and they step up and go, hey, we want to go ahead and do this.
We're done.
Yeah. Well, we want to go ahead and do this. How does that conversation go? And who makes the decision on, okay, we can go ahead and do that, or no, it's not time?
Yeah.
Like,
well, at the end of the day, the referral comes to hospice. We go out and evaluate. So that would lead me then to, there are certain guidelines, LCD guidelines, local coverage determinants that say, yes, for this diagnosis, this person meets all these criteria, and they are eligible for hospice. And then that's their choice. They go on hospice, you know?
Yeah.
So it's case by case, you know? It's a little bit different if it's, for example, a chronic lung disease or heart disease or something like that.
okay.
Somebody that's, and as a matter of fact, there are sometimes when a person doesn't even meet all those guidelines, but yet their life expectancy is still going to be 6 months or less because they're having frequent infections, frequent falls, that sort of thing. So you really have to know how to, like you said, read the room.
So it's fluid, man.
It's
I mean,
fluid,
things
yeah.
start happening, or you gotta be nimble and
it is something, it's just, if you have a little bit more time with a family as opposed to days or weeks, you really get a chance for them to trust you and to know you, and for you to know them and trust them.
Well, it gives them a chance to settle into the experience,
Right.
I think, too, because if it happens, if it's referred out too late, then it's a scramble. Everyone's kind of just making things happen. And, you know,
really
maybe you don't
stressful.
get choice of care. Maybe you don't. And, you know, like in your mom, 2 weeks on hospice, that
not
was
very
quick.
much.
no. And I remember,
Not that it was a bad experience, but it was just, that's fast.
no. I look back on it and I think it was right on.
Yeah.
Like I don't look back on it going,
You wouldn't want to have been doing
there's
that.
no negative. Yeah, I don't have like, I wish that would have gone differently in this sense or something. Like, mom had a chance to come home. The equipment was delivered. Like, everything was well done.
That's
like,
another point I did make.
Yeah, go ahead. Yeah, please.
Hospice includes all that durable medical equipment that you're talking about.
No, it was amazing.
Yeah.
Like, so she's at the hospital. The decision's been made. The company has been chosen. Now things are moving. Mom is being prepared to be delivered by ambulance to the house from the hospital. The equipment's coming. Everything was
The bad meaning the bad, the
Totally.
oxygen, the wheelchair,
even
anything you
stuff
might
that
need.
they say we're not telling you have to use this stuff, but you're going to have it here.
Yeah.
She may not want oxygen. She
Yeah.
may not need it.
Yeah.
You know, everyone's different, but you have these things.
That's right.
We're bringing all the other toiletry kind of stuff. And,
Right. All the
okay, let's get your medications going. And
That's all delivered.
It was, I mean, if you don't,
It's kind of a choreography. Oops, I just
It is. It's a dance.
A lot of different disciplines there.
Totally. Yeah, and then but mom had a chance to get settled in for a few days, and then her health started declining. But we
Because
were
you know
so
what? I
happy
bet
that
we hadn't
waited.
Yeah.
And then now she's unconscious being delivered to the house and she doesn't know she's at the house. That's
Oh,
that's
man.
not the best experience.
No, because I can tell you, my mom was on a hospice in a hospital, like a wing they had out in the desert. It was horrible, and I can't even tell you who it was called, so I can't even name names. But I was a hospital nurse at the time, and I didn't understand. All I knew was she did not look comfortable.
Yeah.
And I think back on that because nobody's mom should go through that. Nobody should, but especially not your mom.
Yeah.
So
Right.
it sounds like it was a really good experience for you.
It was. So let's talk about that too. So patient passes.
Yep.
Does your job stop?
Next worst thing that's
What's
going to
next?
happen.
Yeah, right. That's right.
And I always I like to prepare people because when you've been through something, for most people, there's not a dress rehearsal for this. But when you have been through it, you kind of go, gosh, should I say this? Is this a family that I think will receive this information well? But, okay, person passes, whether I'm there, which I am sometimes, or it's the middle of the night and the nighttime person goes out, or I leave and an hour later they call me. I go, I pronounce them, I call the mortuary. That's our job. The only job the family has is to let us know. That's it. We call the mortuary. We get rid of the equipment. We waste the meds, all that kind of stuff. But the last hardest thing for the family is when the mortuary comes and takes their loved one away. Some people don't want to see it. Some people want to complete that journey, complete that process because out of respect, out of whatever, not everybody's capable of that. So, but I do like to warn people because not everybody's like, oh God, that's going to happen now. So
Yeah.
they don't get it.
So it's a shocking experience.
It is a shocking experience.
But lessen the shock. Like some people preparing doesn't prepare you at all. Like you can sit there, it's like anything in life, like big life moments. You're like, okay, you're like psyching yourself up. You're like, okay, this is how it's going to go. You can have someone tell you a million times and then you're like, I know. But that's part of life, right?
I know.
This is living with death.
Living with death, yeah.
Right? I mean,
it's part of it. I always say we make children such a part of the birthing experience, but then when it comes to dying, we shield them from it, And I don't think that's right because then everybody grows up being afraid of death,
right?
And it can be a beautiful thing,
Sure.
We just have to accept it, and we have to give those people who are, we use the same terminology. We use transitioning, just like when a woman in labor is transitioning. We use transitioning in death. It's hard work. And so we want to make it as easy for them and as accepting for them by giving them permission to go. So.
Wow.
Yeah.
I don't know if this was on your
no, please.
Yeah, no, we're kind of going off.
No, but
we're good.
When you were talking about that, I thought of bedside manner. That just kept popping up to me because our son Parker that passed away.
Right.
That was the one thing that we absolutely we had a bad experience. Is there was a physician, very tenured, set in his ways, and we had an experience where he came in kind of. They're looking at all the numbers that I don't know what they mean. And
was it in the hospital?
It was in the hospital, and he, under his breath, as he walked out, he said 30 minutes. And it's just like,
wow,
you SOB.
That's pretty rude.
And we at that point, Parker was already unhooked from everything other than like the heart monitor, and we were laying in a bed with him, and it was dark, and it was just like.
What could have been a beautiful experience?
That's the last thing I hear. And
yeah.
what made it a beautiful experience is that Parker lived for about another 3 hours.
Ha!
That's right.
And we were singing songs, and we were, at one point we laughed because I gotta go to the bathroom.
Yeah, you gotta live.
You gotta
Things
live.
are still happening.
That's right.
We had
How can all that
bathroom
still be
breaks.
happening when this is happening?
Right.
Yeah.
But I agree. It's as much as we've been kind of taught to not talk about death or it's a scary, avoid it. I think there is also a very beautiful part of the life experience.
And there's you still respect that body. I mean, I can't
Yes.
tell you how many times I've caught myself, taking a piece of tape off, gently, because I don't want to hurt them. But then I'm like, well, this isn't going to hurt, but you still do that,
Yes.
because there's a respect.
There's respect.
There's
right.
respect, yeah. And,
Yeah.
it's really something. But,
Yeah.
so I don't know. I just
I guess just the whole bedside manner thing
Yeah,
was. I mean, I just like any profession, there's good doctors and bad doctors. There's good advisors and bad advisors.
Yeah.
I'm sure there's advisors out there that have no filter and come across abrasive.
Yes.
And that doctor might have been bringing his own experiences into it. He might have been afraid or just uncomfortable.
Totally.
I don't think so.
But nevertheless, you remember that.
I don't think so.
Yeah. Okay. Gotcha.
But besides the point.
Yeah.
Yeah.
So
Wow.
I think a lot of people, I don't think they're as afraid of dying as much as they are of being in pain.
Right.
So,
Interesting.
But
Yeah.
not everybody, James.
so the concept of dying, like
Yeah.
it seems like when people think about life, maybe something that brings them a little peace is life, understanding that life's going to continue. Like, because a lot of people are worried, I'm going to, everyone's going to be sad and they're going to miss me. And that's going to be a burden even after I'm gone.
Oh, right. Yeah.
So how does that come into play in what you've seen with patients? Is that a biggest fear
Pain?
of being in pain? Like, because different diagnosis, there's different
Different kinds of pain.
there's
for
different
Sure.
end of life moments that can be far more painful than others based on what they're going through.
Well, there's a lot of discomforts, and then there's pain. It just depends on the diagnosis. So if you're talking emotional pain, it's important to give that person permission to go.
Sure.
So they're not worried about their loved ones left behind. If it's physical pain, some people would rather feel a little pain and be a little bit more alert, which is always a little bit hard for me because I hate to see them hurting.
Mm-hmm.
Other people are just like, snow me, give me everything you can.
That's
I don't want it. I don't want to feel it.
so those that know me, I played, at a fairly high level of baseball in college and a little beyond. And that reminds me of what one of our strength coaches used to tell us. If you're in pain, pain's temporary and pain means you're alive.
Yeah, yes, exactly.
And
I
that
think
doesn't
that's
help.
exactly
That didn't
right.
help when we were getting beat down.
As you're cursing him. Yeah,
I'm like,
right.
well, I'm really alive. I've never felt more alive.
Great.
Yeah.
Yeah, pain means you're alive. So for some people it does, yeah. But
Yeah.
for those that want really good pain management, I like to, at least I hope and think that I've learned a lot about pain management over the years and what I think the plan should be for people. And I'm able to assess it and then give that back to the doctors because we are the eyes and ears for the doctors out there.
Right.
They're not out there. We're the ones giving them the report and they have to rely on what we're saying. So,
How much, I got a couple questions.
Sure.
How much discretion does the family have as far as pain management too?
oh gosh.
Meaning, hey,
Yeah,
let's say mom
that's
let's
a
say
loaded
mom's
question.
incapacitated, like she's I don't know, had a stroke. She's cognitive issues. She can't make that decision.
Well, cognitive issues usually aren't that physically painful, really.
Okay.
You know,
Oh, that's true.
we're talking about, let's say it's cancer with bone metastasis.
Yeah, it's
that's gonna be-
it's
that's gonna be painful.
metastasized and it's everywhere now. Yeah.
That's gonna be painful. The frustrating thing for me as the person they're trying to help you is, oh no, they're gonna get addicted. Really? That's not something we're worried
I
about
think it's
right
the least
now.
of our worries at
Yeah.
this point.
They're still thinking of them as they're gonna get better, and we can't have them addicted to drugs now.
Yeah.
That's-
Sometimes.
that's
That doesn't
interesting.
happen all the time, but it happens. So, like I was telling you before, we try to work with the family and just say, look, just trust me on this. This is going to help them. Their quality of life is going to be so much better if you just let me medicate them a little bit.
Yeah.
Oh, but now they're going to be all constipated. Don't worry, we're going to work with that too.
Right.
So,
We- And then my other question for you was, you talked about giving them permission to go, to pass. Is that really where the social worker comes in, or is that a combination of both of you? I mean,
Oh no, that's everybody.
and is that a direct conversation to the patient? I would
Yeah,
assume,
well, I
right?
can't.
Yeah.
I've said that a million times to
Okay.
the patient. You know, it's okay. Your person, whoever it is, they're going to be fine. It's okay. And then the family member will say the same thing. You know, we've given them permission to go, and then it'll be like, okay, well, who are they waiting for? Is there a phone call? Is there a family member out of state? Is
Yeah.
there somebody that they're waiting
Yeah,
for?
what's the dynamic? Yeah.
Yeah, so a lot of times we'll say, get so-and-so on the phone and just let
Yeah.
them hear that voice, you know? And I've, personally in my own life, I've experienced that to be true. So,
I was
although-
going to ask you that, but
Yeah.
I didn't want to. Okay.
No, I
Interesting. I can see that. I
yeah.
believe in that. Yeah.
I've definitely experienced that to be true. So that person who's in a comatose state, we believe that they can still hear. They can hear everything we're saying to them. So
Yeah.
don't talk about how funny, you know, don't talk about things in front of them because they can hear it. you
Yeah,
know?
don't tell an embarrassing story. They might get a little.
You want it to be, oh, and then,
All of a sudden they're blushing.
Yeah. They're all whoa. What'd you say about me?
you know, and also every family dynamic is different. There are huge gregarious families that it's just like a frat house around these people.
Yeah.
And I'm sort of thinking, oh gosh, this should be a peaceful thing. But maybe for that person, that's what's normal to them, and they like all the people around.
Yeah. Yeah.
You know?
Yeah. It's hard to also control that part
Oh
of it too.
yeah, you can't control.
What does all this cost?
Oh, that's a perfect question, because that is a question we have, people have. Okay, it's a Medicare benefit.
Huh.
There is no cost if you're of Medicare age.
Mm-hmm.
If you're younger than Medicare age, we usually just contract without insurance.
Okay.
And so there's no cost there. I'll tell you, boy, this could be a whole
Oh,
separate
yeah, I'm
conversation,
sure.
but where the cost comes in is if you need private caregiving. If your person needs around-the-clock care, because hospice is segmental.
Okay. Yeah.
I'm
right.
there 2 to 3 times a week, but for a short period of time. I'm not hanging out all day.
Yeah.
I do what I need to do, manage everything, and I go. Bath aide comes in, leaves. Social worker comes in, leaves. If your person is bedbound and needs around-the-clock care, that can be prohibitively expensive for a lot
Right.
of people. And I'm talking $10,000 to $15,000 a month.
Yeah.
So- Yeah, but that's completely separate from hospice.
Yeah. Wow. So a lot of people
Scary.
think, end of life, they're walking alone.
Yeah.
Clearly not the case after speaking with you and your, and our various experiences personally. I think this is a good time to kind of wrap this.
Okay.
This has been a good conversation, a heavy conversation, different conversation
Yeah.
today.
Yeah, it's normal for me.
Yeah.
Normal for me to talk to you guys about it,
Yeah.
but it's not normal for a lot of
But
people.
it's one that's needed.
Yeah.
Like you were talking about
100%.
the whole idea of avoiding death or not wanting to talk about death or end of life. I mean, we it happens all the time, but we need to be in front of it. We need to have dialogue around it. And
Yeah.
I have a takeaway. Is
Please.
We often recommend that clients, as they're getting older, that we have family meetings.
Yeah.
And it's to talk about their finances, and it's to talk about have this conversation around who's in charge of what should something happen.
Right.
Okay, so that way everyone has an idea of what their role is, and it may not be I'm gonna balance a checkbook or I'm paying bills. And maybe it's all right. I'm on groceries and I do different things.
Yeah, you're in charge of lunch, right? Like or
But
whatever.
this conversation, without this conversation ahead of time, I think you're running the risk of emotions running way higher than they really need to in a very fragile
I'll tell you
time.
something, Ruben. Death brings out the best and the worst in people.
Totally,
So
absolutely, and for whatever reason, it may bring out some animosity that they've had for their whole childhood against a sibling, and now they're fighting over something that this is not the time to be addressing. So
Totally. Talk about a stain on the memory.
Yes.
Right.
It's already hard enough.
Exactly.
Wow.
So
Yeah. Any parting words or advice that we didn't cover that you want to leave us with?
I'm happy to help anybody out in this community that
so
needs help.
how does that work? Like, is it a situation where someone's like, I watched the show with Sandy. I really like her. I actually have a family member that is probably going to need this soon. Can they just literally reach out and hire you guys? Like,
Well, sure, it's the same process.
Is there a situation where you're like, oh, we don't cover that area, or?
For me personally, I'm San Clemente, San Juan, Dana Point.
And you have say in if someone says, I want you to be my hospice nurse.
Yeah,
It's not like, well, we're going to have Jenny do it or something.
The only time it would be a no would be if I was way full, if my caseload was way too full, because then I couldn't do a good job.
Yeah.
So. But you know what? That's fluid. Changes every week or two.
Yeah. No,
it's the nature of the business, I guess.
Yeah.
Right. Well, thanks for spending a little time with
You're
us.
welcome. Thank you.
I really appreciate this. This was a great
This was a needed, necessary conversation, and you made it great.
I hope I helped somebody. If one person got something out of it,
I did.
Like they can choose who they want. That's the really important message.
No, and knowing you for years now, you are the right person for the job.
Thank you.
You bring a smile to it, and I'm sure the families really appreciate you.
Do my best. I'll keep doing my best.
Yeah.
Thanks.
And to our viewers, thank you for joining us in our digital barbershop. If you're living your life and you have your health, you're the wealthiest person in the world. Thanks.